We're going to go ahead and get started. Welcome, everyone. I wanted to welcome you all to the webinar. For those of you who don't know me, I'm Dr. Lauren Levine. I am your host and moderator for the webinar. We have an amazing turnout today. We have close to 700 people that are registered. I'm going to do a little bit of housekeeping first so that Dr. Shaalan can speak for as long as he needs. We want to take questions at the end, and most of you have been on webinars in the past. You know how it works. We can't do verbal questions with 700 people, obviously. On your screen, you have that GoToWebinar control panel. You can just go ahead and type in your questions as you think about them. We don't normally get to the questions until the end. Depending on how long the presentation takes, that may limit how much time we have for questions. We usually get to all the questions, but I just never know. Sometimes there's 5 questions and sometimes there's 75 questions, but we're going to do our best to get to as many questions as possible. In the next few days, look for a couple of things. First off, the webinar is recorded, like as with all my webinars. You will get an email with a link to download that recording. So don't worry if you get distracted, if you have to go somewhere else for a few minutes, you're not going to miss anything. During the webinar, Dr. Shaalan is going to show some of the systems and products that he uses, a few which are exclusive to Golden Dental Solutions. I want to thank Golden Dent for sponsoring these webinars. I have worked with Kurt and Jason for well over 10 years now. They're the ones that are bringing in these amazing speakers. They work with the speakers to develop the content. They handle the CE, which we'll talk about in a second. They're also going to make a special offer to everyone at the end of the webinar. So please stay tuned because that webinar is usually for a short period of time only. I get a number of emails after the webinar always asking about the CE. I'm going to try to mention it at least a few times this evening. Basically, there's nothing that you need to do. We record when you logged in. We record when you logged out. If you're calling in and you didn't actually log in with a link, there's no way for us to know that you're here. Some people in the past have just phoned in. It's a visual presentation. It's a PowerPoint. So you have to be logged in. But based on how much time you spent in the webinar, we'll determine if you get the CE form. You need to have been here for at least, I think, 2/3 or 3/4 of what it is of the webinar. That can take a little bit of time. Normally, they would get it out within 3 or 4 days. There's a weekend ahead of us right now, so it may take a little bit longer. Keep an eye on your inbox because they do send them out. But there's no test that you need to take. There's no quiz. There's no registration. Just log out when you're done. We handle it all on our end. So with that out of the way, I'm thrilled to welcome Dr. Osama Shaalan. He's a globally recognized expert in minimally invasive and aesthetic restorative dentistry. He's based in Muscat, Oman. He's a graduate with honors from Sinai University in 2013 and has dedicated his career to advancing the art and science of composite and adhesive restorations. He holds numerous prestigious leadership roles in the international dental community. He's the county chairperson for Oman at the European Society of Cosmetic Dentistry. He's a certified member of that society. He's a fellow of the International Academy of Dental Facial Aesthetics, the Style Italiano Gold member. He's the first dentist in the Middle East to receive that recognition. He's the author and co-author of many articles and book chapters focused on restorative dentistry, with a special emphasis on practical and minimally invasive protocols. He's also an inventor. He's invented several innovative dental instruments designed to enhance restorative precision, like the LM posterior replica instrument, the Unica proximal matrix, the LM anterior replica instrument. As an international speaker and educator, he's conducted hands-on courses and lectures in over 25 countries, sharing simplified aesthetic composite techniques that empower clinicians around the world. Among his honors are the Style Italiano Best Follower Award, the Youngest and Most Promising Dentist Award from ESCDD. He's included in the top 100 doctors in the world by the Global Summit Institute. That was this year. He currently practices at Mamura Royal Clinic in Muscat, Oman, where he delivers evidence-based, patient-centered care with a focus on long-term function and aesthetics. Dr. Shaalan, we are thrilled to have you here and looking forward to the presentation. Take it away.
Thank you, Dr. Lauren, for this introduction. Hi, everyone. First of all, I want to thank you for attending this webinar, and I always want to thank Golden for these invitations. And you know, this lecture is all about the smile. So smile makeover with a direct composite veneer, the simplified approach. So let's begin, and we start because we have a limited time, and I need to make the lecture as much as possible. So smile makeover with a direct composite veneer, the simplified approach. And if we want to talk first about the smile, you know that the smile as a dentist, it's very important for us. We know for anyone, for self-confidence, for daily relationships, for social integrations, and also for communications. And one of the most problem that we have when the patient presents in our clinic, we have two main problems. Either there is a problem in the color of the teeth, like the presence of we can say discoloration, maybe intrinsic discoloration or extrinsic discoloration, or there is a defective composite restoration that causes the discoloration, or there is a decay also or a caries that causes the discoloration, or there is a problem in the shape of the teeth, like the presence of big shape lateral or presence of small teeth in relation to the arch, or presence of single or multiple diastema, or a combination defect between the shape and the color. And we know that as we are a dentist, we not only treating teeth, and this is very important for our professions, because we are dealing with the human beings, and I mean that we should always respect the patient's needs. And when deciding the treatment plan, and I always, when I give lectures, I put these slides because this is very important. It's not about doing the treatment. It's about respecting the patient's needs. So when providing the treatment plan or putting the treatment plan for the patient, we need to put a treatment plan with integration between the biology, structure, function, and aesthetics. And we know that the current dental philosophy is to preserve as much as possible from the two structures. And one of the most important things that we should respond to the aesthetics and functional expectation of the patient. This can be done by be minimal invasive or to go less invasive. And if we want to go minimal invasive, as I said before, we can do bleaching, for example, to be minimal invasive, or we can do resin filtrations. Also, we can do microabrasions. We can do direct composite restorations, as I will show you in this webinar, or we can do indirect partial ceramics. Or sometimes we can do a combination between them to have to be a minimal invasive and to provide the patient the treatment they deserve. And if we look at this is a case of a young lady come to my clinic just only complaining that my teeth is yellow. So I can do many treatments, give the patient many treatment options, but I need to respect the patient's needs. So I advise the patient that we can, if there is only a problem in the color of the teeth, we can just only do bleaching or home bleaching. We know that home bleaching, it's minimal invasive, safe, efficient, and this is share time as compared to the alternative options. So I make a reference, cross polarized image, and then I prepared the custom tray and the gel, and it was 16% carbamide peroxide and the daily wear from 1 to 2 hours. And we know that reduced wear time with a stronger peroxide concentration is becoming more popular with patients that do not have any issue with sensitivity. This is after 4 weeks, after approximately 1 month, the patient is very satisfied with the result. So this is how we can respect the patient needs. This is how we can provide the patient the treatment they deserve in a very short time. Or we can do direct composite restorations. So why should we do direct composite restorations? We do direct composite restorations because most of our daily work is direct. And we know that we need two things. We need the knowledge and also we need the skills to do direct composite restoration, because 85% of our daily work is direct. Imagine that you have the knowledge, but you don't have the skills. And we know that the skills, it can be gained only by daily training and practicing. Daily training and practice, we can gain the skills. So in this webinar, I can give you the knowledge, but I cannot give you the skills. So it's need practicing and it's need training in a predictable approach. And And the second thing is minimal invasive as compared to other alternative options. And I can show you hundreds of cases that I go only additive without removal from the enamel surface, just adding to the enamel surface. And there is some exception, or there is some scenario I can do some preparations just to correct, sometimes to correct the shape, or if there is mild misalignments, or if there is severe discolorations and I need to create a room for the composite material to mask the discolorations. And also it can be done in a single visit as compared to other alternative option, or indirect, or emax veneer. At least we need from 2 to 3 visits. And also it's affordable. Why it's affordable? Because less time, less material, and also less steps as compared to other options. And finally, it can be easily repaired or replaced in a single visit. So if you have a problem, or you have a broken crown, or broken zirconia crown, or broken emax veneer, so the repairing process, it's very complex. But here, it's very simple. Regarding the composites, it can be easily repaired and sometimes replaced in the same visit. So how we can achieve simplicity in direct daily work? Imagine you have a case like doing a composite veneer from premolar to premolar, like 8 teeth from 8 teeth or 10 teeth. And sometimes we feel lost, because sometimes we're thinking about the time of the procedure, how much time we need to finish this case. And also, as I said before, hand skills is very important, because if I don't have the hand skills, also the time will increase. And also, if I don't have the hand skills, the amount of the stress also will increase. So we need to follow a predictable and also a repeatable, or we can say a simplified approach of direct veneering. So I did this case 7 years ago, and it's for a young lady come to my clinic just complaining that she needs to close the spaces and also to enhance her smile. And if we see there is a defective composite restorations and for broken restorations, and I go to the traditional technique, I just have the primary impression, then sending to the lab to make the wax up, then the silicone index. And if we see the first visit, the second visit, sorry, we do for rubber dam isolation, floss ligation, removing the old composite, etching, bonding, and using the silicone index to build the battle shell. And one of the most important steps, that's if we build the outer shape, or we can say the outer frame, because if we build the outer frame, we can control the amount of the material, we can control the layering from inside. Also, we can decrease the time of the finishing and polishing, because we predicted the final shape. And then continue dentine layering, body dentine, characterization of the incisor edges. And if we look at the finishing and polishing, too many steps for finishings, and also too many steps for polishing. A lot of steps, too much material, a lot of time, and also a lot of stress. And if we see at this paper, about 48% of newly graduated dentists experience burnout in the first 5 years. What is burnout? Burnout is the state of being extremely tired, not only physically, but mentally, because you have worked too hard. Why burnout? Because we are following unpredictable approach, because sometimes we are working randomly. There is no predictability in our procedure. So we need to simplify our daily work. So I will give you just 1 minute to make this survey, because I have a purpose from this survey. If you have internet, you can direct scan the code, and I give you 1 minute to make this survey and answer the questions, and then we will continue. So this is online. So I did survey for now, it's more than 700 dentists online. So one of the most important questions for me was, what is the most time consuming and challenging steps in direct anterior restorations? About 50 53 or 54, we can say they have a problem selecting the composite material. They have a problem that they don't how they make the layering. And they have a problem rubber dam isolations and also the finishing and polishing. And finally, for 14%, they have a problem in matrix placement, or we can say the matrix selections. So in this webinar, we need to simplify. We need to simplify the total work of our work, the daily work. So what is simplicity? Simplicity is something that easy to understand, easy to do without effort, and to be done in a very short time. And if I want to do a direct composite restoration, even anterior or posterior, what we need? We need a restorative material that can be easy to understand in terms of shades, in terms of opacities, and also can be easily manipulated. And also we need a proper instrument that facilitate handling and manipulations of the composite material. And also we need a matrix system that can visualize and predict the final shape of the restoration, even sometimes if I don't have a silicon index or a wax up. And finally, we need a simplified finishing and polishing. I don't need too many steps for finishing and polishing. This is how we can make our daily work more predictable and repeatable. So I will show the protocol now with this case. So this is a case for a young lady come to my clinic complaining, my teeth, there is a yellow, brownish discoloration in the teeth, and the patients need to smile more confidently. So if we look at the restorative view, and if we say there is a fluorosis in the under our teeth, with many discolorations from our left to the right canines, yellowish to brownish discolorations. And we know that the treatment of the fluorosis depends mainly on the severity of the affected enamel. Sometimes we can do bleaching, sometimes we can do microabrasion, sometimes we can do resin filtrations, or a combination according to the severity of the fluorosis. Or we can do composite veneer, or we can do image veneer. But according to the patient limited time and limited budget, we go for a composite veneer, just only in a single visit. So the aim of this treatment is to enhance the color of the teeth, and at the same time, we will enhance also the shape of the teeth. We correct the incisor aperture aesthetically and also functional. So I have in my clinic, this is a custom shades, and if we see the lower teeth, the color is relatively normal. So I need to select a color that's also to be harmonious with the lower teeth. So then we go for a very minimal preparation just to remove the superficial affected layer of the enamel, because it will impair the bonding. Because if we need to enhance the bond between the resin and the sound enamel, we need to remove the superficial affected layers of the enamel. Then we go for the layering. So I have three recipes for layering. Either I can go one dentine shade. This is simple and fast, or I can go for one dentine shade and only enamel characterizing the incisor edge. This is simple, fast, more natural. Or we can go one dentine shades and one enamel covering the entire labial surface, but we have a problem here that we cannot control the final enamel at the final labial surface, because we need to control the final enamel to be 0.5. Because increasing the thickness beyond 0.5, sometimes we will have a gray or blue effect, and this is the problem of the enamel. And sometimes I call the enamel, this is dangerous shades, and we should be careful when using the enamel. We should using the enamel in a very little amount. So I always do, in my cases, I always go for simplified layering, just only one shades and only a little enamel characterizing the incisor. It's just only, no need to use the enamel covering the entire labial surface, because most of the translucency or the translucent effect or the polysens effect is only at the incisor edge, and there is no need to cover the entire labial surface with enamel. After that, if there is severe discolorations, we can use a masking agent instead of preparing too much from the enamel surface, and also to instead of like adding 1 millimeter, for example, of dentine or body dentine, we can add it only 0.5 body shade or dentine shade or a base composite. So we go directly now with the split dam isolations, and why I'm going to split dam, not a full rubber dam isolation. If the gingiva is healthy, there is no bleeding, there is no gingivitis, I can go with a split dam. And also at the same time, I am using split dam because also I will use a matrix, specific matrix that can seal the cervical part. Itching for 30 seconds because the restoration is mainly in the sound enamel, and we should be careful when washing the entire itching and should be washing with water for 60 seconds until we're removing the entire itching remains. And then we have a frosty or chalky white appearance to ensure that we have a sufficient itching. After that, bonding and universal adhesive rubbing for 20 seconds to make sure that the bonding or the adhesive that interact perfectly with all the itched enamel. Then the liticure. What about the liticure? One of the most critical steps when doing any composite restorations is the liticure. So I need to invest in my liticure. First, it's about the head size, because if I need to go with a head size like from 7 millimeter, it will be, I need to multiple site exposures. If I do the incisal middle, I need also to do the cervical. Or we can go for a large head size that cover the entire central incisors instead of doing multiple site exposure. And also, I should use also third generation liticure. And if we want to use like a second generation liticure, and you know that most of the photoinitiators that present in the common system is called the Composite Veneer. And it's yellow in color, and the absorption peaks from 465 to 470. And it can be easily activated by the second generation liticure. But this is a problem when we want to make like a translucent shade or a white shade or a bleed shade. This potentially will affect the final color of the or the final shades or the final color of the shade. So, or the composite. So they added the TBO. The absorption peak, it's white, and the absorption peak, it's below 400 nanometer. It's cannot be activated by the second generation. So I need to use a broad spectrum or polywave liticure that can capable of curing all the wavelengths of the photoinitiators inside all the composite system. This I can make sure that I can make a perfect polymerizations for the bond layer and also for the composite material. So what is responsible for the color change? The first reason for responsibility for the color change is undercuring. So if I do undercuring, so there will be like free monomers, there will be oxidations of unpolymerized monomer and amine accelerator, and also this will be a water absorption, and after that will be internal discolorations. So we need to be careful about the liticure and should be having the proper liticure. Then, as I want to go for a single visit, I make the palatal shell just only with a minor step support lightly with the finger with enamel shell. With enamel shades. Then if a little adjustment, sometimes I need to correct the lengths between the right and left. So the question now, how we can predict the labial contour of the composite veneer? Simply by choosing the right matrix. There are two types of the matrix. For me, I am using the Unica matrix system. There is normal Unica and there is sectional Unica. The normal Unica, it's a U-shaped matrix. It's a 30 microns stainless steel. Regular Unica is for large teeth like central incisors and canine, and mini deep for small teeth like lateral incisors and lower anterior. The mini deep is soft, malleable, so if it's deformed, it can be easily reshaped. But the regular Unica, it's hard to stainless steel. If it deformed, it cannot be reshaped. But regarding the Unica proximal, it's a sectional matrix. It can follow and adapt the labial contour of the anterior teeth perfectly. And also, it's a self-stabilizing matrix. Sometimes I don't need to use wedges to stabilize this matrix or to secure this matrix. Why? Because if you see it has at the cervical part have a split or have a concavity, or it can adapt the papilla and can be placed between the papilla and the tooth inside the sulcus perfectly, there is no need to use any type of wedges. So after placing the Unica matrix, so I have two types now, regular Unica and mini deep, regular for central, mini deep for for lateral incisor. And if we look at the outer shape, I can predict now the final shape of the veneer. And also I can predict what? The midline, the symmetry between the right and left very easily. And as I said before, if I do this, I can easily do the unique frame. So I can build the proximal walls with the same dentine shade of the veneering material. So we need also in these steps, why we are doing the unique frame? Because we predict the final shape of the restoration very easily. We control the amount of the veneering material instead of having a bulky restoration or a bulky material. And this will increase the time of the finishing and polishing. Also decrease the time of the finishing and polishing, decrease the overall time of stress. Even your assistant in your clinic, he can continue after this step very easily, because I think finishing and polishing, we can do the finishing and polishing for 8 teeth or 10 teeth in just 15 to 20 minutes, just only if we do the frame or the outer shape. Then handling and manipulation. As long as going for a composite veneer, I need wide active tip instruments. I don't need to go for a narrow active tip instrument. So this is why sometimes I go for the anterior solo. So I will show you also the good manipulation start from the tube itself. Holding a material like this, irregular, unhomogeneous, will produce irregularity on the surface and also increase the possibility of having voids and bubbles inside the surface, and it will be careful. So when carrying the amount from the tube, we need to be homogeneous. And for smaller cavities, we will have a smaller amount. For larger, we have larger amount. So if I want to layer the dentine, we should layer the dentine in one bulk layer. And if we want to layer the enamel, this is for anterior, in one bulk layer. There is no need to go for incremental. Going incremental means that increased possibility of having air voids inside the layer. There is also increasing possibility of having contaminations in between the layers. Sometimes also I prefer to use what? The capsules. So I can have adaptation under pressure. So I can easily, the comps can be easily adapted. At the same time, I can control the amount of the material. After doing the frame, there is no need to control the thickness, the width of the proximal walls, because we will need to use the same shade for the veneering material. Just if you want to go for just one shade, it's enough. There is no need to characterize the incisor edges. But if you need to characterize the incisor edges, you need to control the layer or the thickness of the proximal wall at the incisor 1/3 to be thin, and to shape the mamelons, and after that adding the layer or enamel layer at the incisor 1/3. And sometimes finishing is necessary as a step. We can do pre-finishing to remove the over contouring cervically and proximally, because we can do something is called leveling. Why? Because if we want to add the material, some teeth will be like over contoured as compared to the adjacent. So we need to level the walls to having the same curve, following the curve of the arch. This is how we can obtain that symmetry between the right and the left very easily. So this is the difference between a wide active tip on instruments. So we have, if we're using a wide active tip instrument, we produce a very smooth surface. And if we use a small active tip instrument, sometimes for composite veneer, it will produce irregularities on the surface. So we need to be careful which active tip we should use. So we can use a narrow active tip for a small cavity. For large surface area, we should use a large active tip instruments to having a very smooth surface, and this is facilitate finishing and polishing. After doing the frame, the dentine should be layered in one bulk layer, and the movement from a sideways movement, not up and down movement. Why? Because going up and down, meaning that the composite will try to go with the instrument, stick with the instrument, and sometimes this will create voids inside the layer. If you need to characterize the incisor edges, you can characterize this step. We can create mamelons, which and the number of mamelons according to the adjacent, or according to the your desire, or according to the patient's expectations. If you need to characterize the incisor edge more and more, we can do like opalescence or clear enamel between the mamelons, but this is a subsurface area, a subsurface layer, not a final layer. Then we can do the final enamel layer, and then we use the modeling brush at the final surface to have a very smooth surface. So what is my rule here? My rule here, it's too much material, it means what? Over contour restoration, and this will increase the time of the finishing and polishing. Improper instruments, it's mean a regular surface, and this will take more time in the finishing polishing because we need to make the regularity very smooth. And improper matrix mean there is a defective in the shape. So if we need to correct the defective shape, so it's very difficult, and also it will require more time for finishing and polishing. So if I do the first step perfectly, I think that the last step will be very easy, especially the finishing and polishing. This is why I'm going just only for steps for finishing and polishing. For simplified finishing and polishing, just only one disc to contour the final shape, one pair to create surface textures, one rubber for pre-polishing, and one twist and one star shape filled for this is Lucidef from the shine for final polishing. So I bring a pencil or any mark. Then I will draw the three facial plane, the medial distal curvature, the transitional lines, the surface textures, and I'll start that starting. So I'm always doing the finishing all the teeth together. So I draw the cervical third for all the teeth, middle third, inside the third, and starting with a coarse disc 45 degrees from cervical, all the teeth, middle, and then incisor. Then the mesodistal half curvatures, because we need to follow the curve of the arch, because there is a curve of the arch, because we finish the two mesial surfaces of the centrals together, then the distal surface of the central with the mesial surface of the lateral, then the distal surface of the lateral and the mesial surface of canine until have the curve of the arch. And after that, we use the pencil to draw the transitional lines, and the same, I use the disc. I don't use pairs. Why? The pair, it can be the pair. Sometimes if I producing more pressure, sometimes it reduce irregularity on the surface. But the disc, first we had finishing a line or a surface area. So I need something that can adapt to the surface area. This is the disc, and also the disc is flexible. Even I do more pressure, it will produce a uniform area. This is why we go from inside to outside, from inside to outside, and sometimes I control the width of the two centrals. Even I can make illusion. If there is some teeth are wider than the adjacent, I can do illusion of narrower or wider tooth by contouring these lines. So then the correction is the incisor pressure, and I use a soft disc, and it's very important to finish the incisor pressure, not only aesthetically, but for functionally. So I need to be careful having the right and the perfect symmetry between the right and the left. About surface textures, I use this pair, it's a diamond pair, to create the surface texture and secondary anatomy, the mesial and distal developmental groove, and we starting from the body of the pair at the incisor edge wider, incisally, and then inclining the pair or curve the pair on the labial surface and narrower cervically until we have the two homogeneous groove with the surface. I don't need to make a sharp grooves in the surface. After that, I go for pre-polishing. This is why I'm using the twist rubber. Why twist rubber? Because it can adapt all the surface details. But be careful, the movement of this rubber should go in a forward direction, not a reverse. Because if you go to the reverse direction of the peaks, it will break. Instead of using this rubber for multiple patients, multiple cases, it can just only one case. Then 45 degree from cervical to incisor with intermittent touch to prevent the overheating of the outer surface. After pre-polishing this, we are ready for the lucid polishing or lucid click. This is from Diashine. Why we are doing polishing? Because there is micro cracks, micro voids on the surface. We need to eliminate all these, and this can accumulate all that can accumulate the pigment. So this is why I need to have the surface gloss or surface clusters to increase also the longevity of the restoration. This is the super active submicron diamond paste that's come with the Lucida. The same kit with the star shape fill that can adapt also the surface details, the interproximal, the labial, and also the occlusal surface of the posterior teeth. This is immediately after. This is 3 weeks follow-up. This is a black contrast. This is side view. side view, and this is the patient is very satisfied with the result. What is the dangerous areas? First, when I mean the midline, and here not all the entire midline between the two, the two arches, but also between when I placing the first two matrices in the centers, there should be perfect symmetry between the two matrices. Any deviation in the matrix there will be a deviation in the midline because there will be also a central dominance. And we know that the focus always in the two centrals. Any discrepancy that is in the centrals can be easily noticeable than that of the lateral incisor and then that of the canine. So need to be careful. The focus always in the two centrals. The transitional lines, and here, or we can say the light lines, and should be symmetry between the right and the left side. And the contact area in relation to the length of the centrals, and especially in cases of what? Diastema or multiple diastema cases, because we need to prevent to having plaque triangle after the restoration. Finally, the incisor imperial should be, there is a light symmetry between the right and the left perfectly. If you need to go more details, in this you can check the Study Italian book 2022. There is a full chapter about this case in details if you want. So I will show you now a video in 3 minutes. So in this video, it's about freehand layering of 4 anterior teeth, 1 hour for layering and 30 minutes. And for me, 30 minutes too much time. So now I can do it in 15 to 20 minutes. I will show you. And so I was using these mylar strips to build the palatal shell. And I always give courses about this technique. If you need to know more details or to have more details about or to learn more about this technique, you can check my website. And you can also check my courses about how we can achieve a predictable palatal shell and the symmetrical between the right and the left very easily. We can adapt them with the unicap, multiple unicap together, and here secured by what? Secured by liquidin or flowable in between them, just to secure the matrices together. And here I using the dentine shades in the proximal walls. There is no need to control the thickness of the width of the proximal wall, just only in the incisor 1/3. Now this is the frame. One bulk layer for dentine, then making mamelons. And after that, the mamelons for the left hand side. Now we'll be placing opalescence mass or clear enamel in between the mamelons. This is the final enamel layer, then starting finishing and polishing. So we are repeating the same steps of the finishing and polishing. Using the coarse disc in the first steps, from cervical to incisal, until we achieve to make the teeth at the same level, the same curvature, because the labial surface is not same plane. There is a 3 facial plane, and also there is curve of the arch from the canine to the canine. We need to draw this curve. The transitional lines, I am using the same disc also. Now we can control the width and symmetry between the two centrals, or making an illusion of wider or narrower tooth by controlling these two lines. Then the surface textures with the pair, wider incisally and narrower cervically, and then the rubber. So there is no need to use extra steps, just only for steps. This is the final steps. We need to clean the surface now for the final photo. So we can do is very simple, as simple as possible in just a very little time. Ciprian, so what is the more simplified also? So I also follow this technique. I use this instrument, the new instrument, the replica anterior instrument. So this instrument just not only adapt the composite, also it adapt the composite, removing the composite excess and shaping the transition lines and also the secondary anatomy in the same steps. So there is no need to use any pairs. So just only using the proximal unica to control the outer shape, and then the one step for pre-polishing and one steps for polishing. So I will show you one sheet. This is a single central initial situation, making freehand at the same steps, using the black side, the back side, sorry, with the curve end to carry the composite material, then using the curve end to adapt and shape the palatal shape. After making the palatal shape, and no need for further adjustment. And sometimes if we go freehand, sometimes a little adjustment is needed. Then we adapt the proximal unica. And now if you see these steps, after placing the unica proximal matrix, use the curve end to slide vertically between the two teeth in the proximal area to establish the proper proximal height according to the adjacent tooth height, mesially and distally. What is good about this matrix? We can control the height before proceeding to build the proximal wall. So I can first, by pushing the matrix more labially or more palatally, so I can make the matrix at the same level of the adjacent before going to build the proximal wall. So there is no need to do extra finishing. There is no need to, there is no chance also to have over contour restorations. So then we slide the instrument from cervical to incisal to have to contour the matrix according to the tooth shape. The same side for the distal sides. Then we adapt, use the sharp cave-in to adapt and shape the proximal wall against the proximal mat. And sometimes, if you see, there is some composite excesses that go beyond the matrix level. What we should do now, we adapt the composite from one side, and then we slide the curved end between the two teeth vertically from cervical to incisal. And then we use the inner side concave of the curved end to adapt the composite cervically to draw and shape the mesotransitional lines, and use the outer side convex of the curved end to adapt the composite cervically to be continuous with the cervical enamel. So we need to flush the composite with the cervical enamel, and there is no chance to have any irregularities or overhang at the cervical margins. The same steps for the distal sides, and then the same steps for removing the composite excess at the distal side. This is the outer frame. And we always make sure that the frame is typically at the same level of the adjacent tooth. And then we go for the veneering material. So we adapt with the outer side of the instrument and from cervical to incisor. And then if you see there is some excess composite at cervical at the proximal wall, so we need to slide the matrix. So the second stage to accentuate the shape and removing the excess while forming the surface anatomy and the transitional lines. After doing these steps, we remove the excess, and at the same time we make the secondary anatomy. And also we can control the depth of the surface textures. If we need, we can make it more prominent, or we can make it a lesser surface textures. And this is the final situation. I will show you. I will go for two shades, and we'll show you the video with the last one. And in this, if I want also to go for two shades, I will just only, after removing the excess, I make a room for the mamelons, and then I make the mamelons at the incisor 1/3. And then after that, I placing the composite enamel in between the mamelons at the incisor as I make a space for the final enamel layer. Then the finishing and polishing with the same steps. So there's no need, just only one rubber for pre-polishing and one steps for the final polishing. Pre-polishing using twist rubber will skip the steps to use the pair to create a surface texture because we already created using an anterior replica. And this is the final polishing, and this is the final situation. So this is how we can produce homogeneous surface textures with the surface, not a sharp or sharp surface texture of the surface. Sometimes when the light hit the surface, we produce a sharp reflections. So we need to go for to use extra steps for frictional polishing to remove these irregularities. Now I will show you this video. So using the curve end to make the palatal shell, this is enamel shade, and we should always control the thickness of the palatal shell to be 0.3 to 0.5. How we can make sure that? We should see the background through the shell. If we see the background, it's within 0.5. The light cure. And now I will show you the magic of the proximal Eureka matrix and how we can place, it's the best way to place the matrix is to place between two fingers, not holding the matrix from the tip. It's placing the matrix between the labial and the palatal side, between the two fingers, and pushing until it reaches the papilla, and embracing the papilla in between the papilla and the tooth inside the sulcus. After that, we adjust the height of the matrix and using the instrument, or I can push using my fingers to have the same level with the adjacent tooth. There is no need to use any type of wedges. Sorry. So I am using the curve end to adapt the composite. Then I am sliding along the matrix and along the interproximal area to remove any composite excess. See how? Like this. So in these steps, we flush the composite with a cervical enamel. So we need to make this area very smooth. The same for the distal side. Then light cure. I will not make light cure until I have a perfect homogeneous proximal walls. This is how we can remove the matrix very easily. We just release it from cervical to incisor, and then we push toward the incisor part. This can be easily removed. Then we use the same dentine shade of the proximal walls. Then now we need to remove the excess, sliding vertically in between the two teeth and removing the excess like this. You see now the depression. We can control this, the secondary anatomy or these depressions. We can control by curving the instrument. Either we can make more permanent or make it more, it's less. Then we create a space for the mamelons with the curve end. Shaping the mamelons with the curve end also the same. And then pulling the mamelons toward the inside edge, and should be from 0.5 to 1 millimeter. Then you use the outer side of queenie to make the depression between the mamelons to allow the final layer of enamel to follow all these depressions. Light the cure, and then we go to the final enamel layer. Or we can put, if you want to characterize more, you can put clear enamel or transparent enamel in between the enamel, the mamelons to have more opalescence effect. Now we're using the outer side now to follow the depressions in between the mamelons, and also at the same time we're starting to create the secondary anatomy. This is the final layer. We're repeating the same steps. I just use these steps, the disc, just only very little to remove the excess at the distal sides, and then continue to the final pre-polishing, just only. There is no need to use on the surface. Because if I want to use on the surface, I will remove the entire surface textures. Now going to the rubbers directly and going through the grooves and the surface textures. Also, we have an options. We can use this is the pre-polishing. Also, we can use the polishing rubber if you want, instead of using the lucida or the stark shape felt. But I always recommend to use the polishing paste as a final, and I mean this one. This is to provide the initial gloss. So see now the surface gloss, the surface texture, everything's in a very simple steps. So let's go fast in the cases. This is a case also for a young lady come to my clinic complaining of discoloration in between teeth. If you see there is defective composite restoration in the between teeth, so we decided to replace these defective composite restorations and at the same time to enhance a little bit the shape and the color. So we decided to do a light the composite restorations from our composite veneer from canine to canine. So going as long as the gingiva is healthy, there is no need, there is no gingivitis, there is no bleeding, we can go for split dam isolation, removing the old composite etching, using the proximal unica with the, and here I use the better shell to make them at following the curve of the arch and the curve of the lower lip. Then continue. This is the final layer, and then the simplified functional polishing or using the lucida polishing for the final steps. So this is immediately after finishing, and you see that I'm moving all the irregularities and the over contouring in the cervical, and this is after complete healing. And this is the side view. This is side view. This is another case for a young lady come after orthodontic finishing the ortho treatment, and she come to my clinic to enhance her smile. And if you look here, there is a old comb restorations. We need to enhance both the color and also the shape of the teeth. And if we look at the two centrals is short in relation to the length of the canines and the curve of the arch. We need to restore the canine, the length of the two centrals and the alignment of the curve with the curve of also the lower lip or the smile curve. So we decided to do a composite veneer from first to premolar to first to premolar. So removing the old composite, the same minor steps to make the better shell with the clear enamel, and with a little adjustment is needed because we need to make the perfect length and width between the two between the teeth. Now it's a multiple unica together from canine to canine. And if you see there is a flowable composite in between, or liquidam, we can say, or flowable stoppers in between. This way we can secure the unica together, and also we can do this if the unica is secure by the palatal shell and the tooth itself. But sometimes if I have a multiple layers or larger spaces, sometimes I need to use wedges in between the two teeth. So this is the unica frame. And we are ready to use the veneering material and then the final enamel layer, finishing and polishing with the same steps. And this is immediately after. This is side view, and this is the complete protocol. This is immediately after. 1 week follow-up, 1 week follow-up. This is 7-month follow-up. And so in this case, I can show you hundreds of cases, not only just like 15 or 50 cases. I can show 100 of cases following a predictable approach or the same approach of direct veneering. So we can consider the composite restorations or the composite veneer as a treatment plan as long as both professional and the patient know that the factor that leading to the restoration failure. So how we can increase the longevity of the direct composite restorations? According to the literature review, if we can say anterior regarding or and compared to the posterior, anterior teeth is like class 3, class 4 restoration up to 10 years, but for posterior teeth like up to 86%, like up to 12 years. So I don't say that after 8 or 10 years or 9 years, the composite will come with the broken restoration. Sometimes we can do maintenance, or sometimes we can do repairing. Or in the worst scenario, we can do replacement. It's very easy, not like any other restorations. So why we can do maintenance? Because we not only maintain the composite restorations, but we need to keep and preserve and protect what? The natural tooth structures. This is the main purpose, not only maintain the restorations, but we need to preserve the natural tooth structures. This is a case, come to my clinic, I do composite veneer, and this is after 2 years and a half. And it's normal to have discoloration after composite, it's normal. But we can do follow-up. This is why after, when you buy a new car, what you do every 6 months or 3 months, you do maintenance, you do service. So this is why we should do this in any composite restorations, or not on composite restoration, any direct or indirect restorations in the oral cavity. We should do maintenance. We do pre-polishing. It's enough to, this is how we can increase the longevity of the restoration up to up to 5 years or up to maybe 7 years more. This is the case come to my clinic with the defective composite restorations. I replace them with a composite veneer, and this is and this is immediately after, and this is after 3 years and 5 months. There is some discolorations, so I do maintenance. I do refinishing and repolishing, and the patient also will be satisfied with the result. And I always do 1 week, 1 month, 3 months, 6 months, 1 year, 2 years, 3 years. At this case, I do after. This is 1 week follow-up after doing the restoration, and this is after 6 years. There is some discoloration in between teeth. Because why there is some difference between, sometimes after 5 years, there's some difference between the composite and the two structures, because the two structures, there is physiological aging. There is normal color change. There will be normal color change between the composite and also between the two structures. This is why after that I do just only repolishing and finishing. This is how we can increase the longevity. So composite restoration can be real world treatment, as long as I said before, both the professional and the patient are aware of the factor that's involved in the restoration failures. So if you want to read more, you can check layer 2. You can check the protocol of dental photography. You can check also start in your book for more details if you go on to see also more about the posterior layer composite restorations. And I always say that simplicity is the ultimate sophistication. So we can follow a simplified approach. We can enhance our daily work, but making something simple, it's not easy. So I give you this recipe because we can make a change. We are a dentist, not only just treating patients, but we can changing the patient, not only the patient smile, but we can change the patient life. And this is one of the highest purpose that we can achieve. So if you want to have anything, if you want to check more, you can check my website, or you can check my YouTube channel or Instagram. You can see a lot of cases, and this is my email. If you also, after this webinar, if you need anything, you can do, and you can send me. Thank you so much for attending this webinar.
Thank you, Dr. Shaalan. So we do have some questions, but before we get that, a couple of things. Number one, I know a number of you logged on a couple of minutes after I had done my introduction. So as a reminder, we do record all these webinars. The recording will be sent out, or probably be sometime early next week, because we're out of Friday right now. The other thing is that the CE credits are done automatically. We see when you log in, we see when you log out. There's nothing that you need to do, no registration or test or anything like that. I send that off to Golden Dental, and they will go through that and send out the CE forms. That usually can take up to a week or so. Speaking of Golden Dent, they're the ones that sponsor these webinars. They bring in these amazing speakers. They always make it a habit of making sure they offer some specials as well. So I'm going to turn it over right now to Jason Phillips from Golden Dent. He's going to make some of those offers and then tell you about some educational opportunities, and then we will go to the questions. So Jason, it's all yours.
Thank you, Dr. Levine. Wonderful presentation today, Dr. Shaalan. Appreciate it. We appreciate all the attendees. So I'm Jason from Golden Dent, and let's see here. For today's webinar, we're offering a 15% discount. The code right there is POLY15, P-O-L-Y 15. It's a great deal. It's good for anything on our website, except for the exclusions there, as you can see. And this is a 72-hour deal. It'll end on Monday, end of day. So please take us up on it. So what's new with us? So you know, if you've been following us for the last year or so, you'll see that we've added a lot of matrix products. And so you know, one of the big things that we hear all the time is, you know, how expensive dental materials and products can be. And so we offer not only a lot of good options as far as lower cost options that work just as well as the big guys, but we also offer unique things, as just like what was focused today in the webinar, between the polydentia unica interior, the new proximal that we just added, and then also these 3 wedges. If you've ever used wood wedges, we'll get that in a second. So here's the proximal matrices that you've seen today. Very unique. From in my history, we're working a little bit, or quite a bit actually, in the matrix arena. We always see that the dentists would use just sideways or lengthwise the traditional sectional matrix band to do what Dr. Shaalan's proximal matrix does very effectively. So if you're interested in that, take a look. It's on our website. The 3 wedge I mentioned just a minute ago, these are a replacement for the Wizard, or the Waterpik Wizard wedges that are not really, or no longer available. They're the same material, birchwood, and so if you were missing those, we have them, and an excellent equivalent for those. Also, this is our new curing light, the Woodpecker X Star. We've had it tested by Dr. Richard Price at Dalhousie University in Halifax, Nova Scotia, and the report is available, or available soon rather, and the bench test shows that it's just as comparable as the Velo X, but less than half the price, so you can save yourself a little money there. We also have the Trick Shot injection comfort device. Works on the gate control theory. You can look at that up on Google, but we've got those. It's a wonderful little device. We've had nothing but good feedback on it so far. Also, you want to save a little money on your digital X-ray sensors. We have these in stock. They've been pretty well accepted, and also we offer support at no charge to the purchaser by Dr. Levine and his digital dentist team. Also, one of the things that Golden Dent is known for is our Amplify live patient training. We do these. It's probably hands down one of the best extraction grafting live patient courses that you can attend. As you can see here, our next one is, our next one is, I think it's the 26th and 27th. I can't see it because it's blocked on my screen, unfortunately. Sorry. But look us up, amplifydental.com, and check it out and see if it might be something that you want to attend. Our next webinar is the 16th of September with Dr. Tim Kaczynski. He's always a great presenter, extremely knowledgeable. He works with a lot of the larger companies in dentistry. I'm sure you heard of him before, but we're going to be putting that one on. Please join us for that. It's a free 1CE webinar. And there again, we've got our 15% discount code. It's good until end of day Monday. Please take us up on it. And again, we appreciate you attending our course today.
Thank you, Jason. I would mention as well, for those of you, Jason, maybe if you want to keep the, do you want to keep the slide up that has the special?
Yes. Sorry.
Perfect. Yeah, so people can see that. It's okay. For Dr. Kaczynski's webinar, we will be sending, all of you who are on the webinar tonight, we'll be sending an invitation for that. I think those will probably start going out in the next couple of weeks, so keep an eye out for that as well. So we do have some questions, Dr. Shaalan. Are you ready?
Yes.
Okay, so are you able to get tight and broad interproximal contacts even without wedging or burnishing?
Yes, exactly. Regarding, as I said before, if I want to compare regarding the contact from anterior and posterior, in posterior it's very critical. But even in anterior, yes, we can achieve tight contact. Just I have a small trick that if you, before curing the proximal walls, you can push the matrix against to the adjacent. And you can do the same with the adjacent tooth, the same. So after removing the two matrices, you will have a very tight contact. So in my courses, when I do the hands-on, when I show this trick to the participants, it's like a magic. So make sure that put the composite and shape the composite of the proximal walls, then push against the adjacent tooth, then light cure, hold, light cure, and do the same with the adjacent tooth. So you will have a very tight contact in anterior teeth.
Okay, good. This question might be more for Jason. Where can they buy or how do they buy the matrices, specifically the proximal ones?
Well, you
Does
go to
Golden
our,
Dent send those individually?
yeah, there go to our website, golden-dent.com, and under matrix systems, you click on there on the left menu. You'll see a section under matrix systems that says anterior matrix. You click on that and you'll see everything on the page there that we have for interior matrix. They come in two different.
We lost you there for a second.
Mm.
Mm-hmm.
You still there, Jason?
All right. Hello?
We lost you there for a second. Yeah, we lost you there for a second.
Oh, I'm sorry. So with golden-dent.com, go to the left menu that's matrix systems, and then under matrix systems, and it's interior matrix, and then you'll see everything interior matrix there, including the proximal matrices.
Perfect. Thank you. So Dr. Shaalan, for people that are maybe struggling with shade matching, I mean, is it supposed to be difficult? Do you have any tips to share on shade matching?
So regarding shade matching, if I want to say like doing a composite veneer, it's very easy. No, there is no challenges used with shades. Like doing a single veneer, it's a big challenge, and also like doing a class 4 restoration. Yes, it's like the problem that we have. Most of the dentists they have how to make a good matching with a composite restoration. So if I want to make a good matching, first I want to go for simple steps. I want to have like the most common used shades like A1, A2, A3 with any system that's composite that I used in my clinic, and then I go for putting the composite. For me, there is two techniques. There is, we can say like a composite button triangle technique, or we can use the custom shades. And for me, I use the custom shade better than the composite button triangle technique, because I have a custom shade from my own composite system that I work with. After that, I make the shade selection under cross polarization. So I make the shade selection and then I take a cross polarized image so that I make sure that the shade, or we can say one of the most important things is the value that's of the restoration or the composite and the two structures are the same. So we can very easily choose, sorry. But if we want just to put the composite on the teeth and then we can make matching by our naked eye, this is not a good option, because if we, all of us, making shade selection with the same shade, we will have a different, everyone will have a different recipe, or everyone will have a different shade selections. So we need to make a simple protocol. First, we will need to make custom shades. For me, I prefer this is the best way. And sometimes I do, with the custom shades, I do something is called realistic triangle. What is realistic triangle? When I make sure that the shade, like for example, A1, I make a direct mockup with the same shade. Like if I have a class 4 restoration, I make the composite, I make without bevel, without etch, without anything, just only adding the composite to close the broken part of the tooth, or to shape the broken part. Then also I make latticure, then I take a cross-polarized image before doing anything. So this had, I can make sure that this shade is perfect in the, and also in the real shape, not only just putting a button on the tooth surface and judging if this button it's the same shade or not. So I always prefer go custom shades, and you should make to if you want to try and to make sure this custom shade is perfect, go for realistic triangle and like making a direct mockup. After that, you go to continue with the procedure. But please first use a cross-polarized filter, either with your mobile or professional camera.
Okay. Could you repeat the name of the composite placing instrument that you were using?
And anterior replica on instruments. Anterior replica on instruments.
Okay, thank you. So let me just see. We had a bunch of questions here. Does the Unica anterior kit come with all the necessary items to get started with doing composite veneers? Does it come with the proximal matrices as well?
So this is a question for me or Jason?
That's a
So
good question. Well, you can.
I can answer
I don't know.
this.
Jason can try.
Yes, I can answer this. So, regarding the Unicad, the normal Unicad, the U-shaped Unicad, there is a called starter kit. In the starter kit, you will find there is a Unica mini deep and Unica regular, and also you will find there is wedges. You find there is a player that can remove the mattress, and also all these. But regarding the Unica proximal, you will just only have the Unica proximal in small box. But now they are preparing a new master kit that include both the proximal Unica and the regular and the normal Unica. So they will put everything in one kit. It will, I think, so. It will be launched in the next months.
Okay. In your practice, what's the ratio of veneer cases to composite? That you do with composite versus lab-made porcelain veneers. What's the percentage?
So this is not like not because I like composite restoration. I don't make like IMAX or porcelain veneers. To be honest, I do porcelain veneers, but if you have a patient like a 15 years old patient, you will do porcelain veneer for this patient or do composite veneer for this or composite restoration. So it's depend mainly on the patient age. It's depend on the patient economy, and this is very important in my country. For example, in here in Middle East, the economy is very important. They are seeking an affordable options. So I always, and to be smart, I need to provide the patient the treatment they deserve. So I can provide the patient like I can tell him that we will do IMAX veneer or porcelain veneer, but sometimes the patient they cannot afford this. Sometimes the patients they don't have like a limited time. They don't have too much time, or they need to a very limited time, limited budget. I go was for composite veneer. But if I have there's no problem in the economy and the patient age like it's beyond like 30, I can go for porcelain veneer, of course.
Okay. We just got a couple more questions here. For the Unica anterior matrix, what's the main reason that someone would use that versus saying just using like a Mylar?
So there is two different things between Mylar strips and Unica matrix. I just only use Mylar strips to build the palatal shell. And I know some dentists, they are using the same Mylar strips to build the proximal wall, but there is a problem here. Why? Because the proximal walls, we need a contoured proximal wall. And if you see the Unica, or especially the proximal Unica or the regular Unica, they have a pre-contoured form of the matrix. So I can adapt the composites very easily, and I have a pre-contoured surface very easily. But regarding the Mylar strips, sometimes if I need to use the Mylar strips to build the proximal walls, I will have straight like proximal walls. And this is not fit to the anatomy of the anterior teeth. But you sometimes maybe you can do it, but you need to have perfect skills, like a lot of skills to do this perfectly. But for me, I just only use a Mylar strips or transparent strips to build the better shell, just only.
Okay. In the case where you showed the lingual buildup, what was the clear composite that you used in that case?
So regarding the composite, the type of composite you mean?
I beg your pardon?
So they mean the type of the brand of the composite, or
I think so. Yeah, I think so. Yeah.
So regarding the palatal shell, as long as I want to go one shade, I can use any type, any dentine or body shades. There is no need to use enamel. But if I want to go like two shades, and want to characterize the incisor edges, I need to use in the palatal shell either enamel shades or transparent shades. I always prefer to go transparent. Why? Because sometimes if I need to go to use enamel shades and increase the thickness, sometimes I don't, in the final restoration, I will not have any translucency because it's the thickness of the palatal shell, it will hide the translucency. The light will not transmit and go through the palatal surface. I always prefer to go like the clear enamel from Tokuyama Belfica X5, or we can use transparent enamel from GC like G81 or G Accord. Or we can go for clear enamel from 3M like Z3 350. This is, you can use any type of enamel as long as you can control the thickness to be not exceeding from 0.3 to 0.5.
Okay. Do you have a favorite anterior composite nanofill and microfill, specifically like the brand of the composite?
So for me now, all the composite system in the world now they are the same. Why? It's not about the composite itself, it's about the technique. So I can bring any composites and I can do the same steps and also having the same luster, having the same polish, having the same gloss. And for me, if I can use many brands and having the same result. So for me, it's not about the composite. It's about the technique itself. If I following the technique, the predictable technique, I can having the same result. You can use UC, you can use Tokuyama, you can use 3M. They are the best for me. And most of the cases here you can either GC or Tokuyama in my lectures.
Right. Makes sense. We are running out of time, so is there anything you'd like to say before we wrap things up for the day?
For me?
Yeah, sure. You get the last word.
So I want first to thanks Mr. Jasons and for the invitation, and also thanks Dr. Lorraine. Thank you so much for kind help and support in this webinar, and also for the attendee and participant. Thank you for attending this webinar. And also, if you need anything and if you have any questions, you can just only send me on my social media. As long as I see your questions, I can answer directly. So don't complicate your life. The life is very easy, and make it simple.
Okay. We are done for the day. I want to thank you, Dr. Shaalan, for sharing your expertise. These are some beautiful cases, and it's really great to see what's being done around the world, and just really very impressive. And we thank you for your time. We'd love to get you back at some point. We'll leave that up to Golden Dent to figure out the when and the how. As I mentioned a couple of times, I'll say it one more time. The webinar was recorded. That recording should go out sometime in the next few days, probably sometime next week, because we're already at Friday. The CE certificates is all handled by Golden Dent. I will send them a list of when you logged in, when you logged out. As long as you were here for the bulk of the webinar, you will be sent to CE. Nothing you need to do. As soon as you log out, you're done. There's no quiz or any registration or anything like that. We do these webinars on a regular basis, as Jason had mentioned. The next one is scheduled with Dr. Kaczynski on September the 16th. All of you who are on the webinar this evening today, I guess it's still early somewhere, but you will be sent the link to register for that webinar. We thank all of you for joining us. I keep doing these webinars because we get great turnouts. We had right around 700 people tonight. They're always going to be free. We're always going to try to bring in great speakers and great content, and we know that your time is valuable, and hopefully all of you appreciate it, and we'll continue to frequent the webinars and continue your dental education. Please stay safe and healthy out there, everyone, and we look forward to seeing all of you on our next webinar. Good night, everyone.